Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is October 3rd, 2025. This video is on a JAMA review on hypothyroidism published online September 3rd, 2025. I have so many patients on replacement thyroxine. So I thought this was an interesting video an interesting article to read and do a video on. What is hypothyroidism? It's a condition of thyroid hormone deficiency affecting metabolism, growth, and cognition. How common is it? Prevalence ranges from 0.3% to 12% worldwide depending on iodine uptake. Who's most at risk? Women, older adults, and those with autoimmune disorders like Hashimoto thyroiditis. What are the typical symptoms? Fatigue, weight gain, cold intolerance, constipation, and memory issues. What causes hypothyroidism? Autoimmunity, iodine imbalance, thyroid surgery, radiation to the neck, and certain drugs. Causes and risk factors. Is it genetic? Yes. Family history of thyroid disease increases risk. What role does iodine play? Both excess and deficiency can cause hypothyroidism. Can surgery or radiation cause it? Yes, especially after neck surgery or radiotherapy. Which medications can trigger it? Amiodarone, lithium, and immune checkpoint inhibitors, the new kids on the block. What syndrome increases risk? Down syndrome and Turner syndrome have a higher prevalence. Symptoms and complications. What are the metabolic symptoms? Cold intolerance, weight gain, and fatigue. How does it affect the heart? Bradycardia, hypertension, and heart failure risk. Cognitive effects, memory loss, difficulty concentrating, and depression. Impact on fertility, irregular cycles, menstrual cycles, infertility, and increased miscarriage risk. Severe form, myxedema coma, which is life-threatening with hypothermia, hypotension, and confusion. Diagnosis and testing. How is it diagnosed? High TSH and low free T4 levels. When to test if symptomatic or at high risk. Example, diabetes, autoimmune diseases. Are antibody tests helpful? Not for diagnosis. May be positive in healthy individuals. Should asymptomatic individuals be screened? Routine screening is not recommended. When to suspect central hypothyroidism? If pituitary or hypothalamic disease is likely. Treatment and monitoring. First-line therapy, levothyroxine or synthetic T4. Lifelong in overt cases. How should it be taken? On an empty stomach, 30 to 60 minutes before food. What dose to start? 1.6 microgram per kilo per day. Lower in older adults or with heart disease. When to check levels? 6 to 8 weeks after starting therapy or dose change, and then once a year. What if TSH is off target? Adjust the dose. Check for adherence or drug interactions. Over and undertreatment. Why avoid overtreatment? Because of the risk of atrial fibrillation, stroke, and bone loss. What defines overtreatment? TSH level less than 0.5 micro international units per liter, common in older adults. What defines undertreatment? TSH above 10. It worsens symptoms and cardiovascular risk. Does switching brands matter? Yeah, it may alter TSH. Monitor closely if switching. Can you de-prescribe levothyroxine? Yes, when started inappropriately or TSH normalizes. Special populations. What about pregnancy? Dose increases by 30% during pregnancy. Monitor TSH every 4 weeks. When to refer to an endocrinologist? In pregnancy, cancer, heart disease, or poor control. Does age affect presentation? Yes, elderly may lack typical signs like weight gain. What about men? They may have low libido, erectile dysfunction, and low testosterone. What's the role of selenium or vitamin D? Not recommended for routine therapy. Eponyms related to hypothyroidism. Hashimoto's thyroiditis, named after Hikaru Hashimoto, 1881 to 1934, a Japanese physician who first described chronic lymphocytic thyroiditis in 1912. The most common cause of primary hypothyroidism in iodine-sufficient regions. The next one is Ord's disease, described by William Miller Ord, 1834 to 1902, a British physician. Refers to atrophic thyroiditis, an autoimmune form of hypothyroidism, distinct from goitrous Hashimoto disease. The next eponym is Gull's disease, described by Sir William Gull, 1816 to 1890, and he described it in 1873. Early clinical description of what later became known as hypothyroidism, especially the adult form associated with mixed edema. Next eponym is Cocker's thyroidectomy complication. Theodore Cocker, 1847 to 1917, Nobel laureate in 1909, described post-op hypothyroidism or mixed edema following total thyroidectomy. He was the first to emphasize the need for subtotal thyroidectomy to preserve thyroid function. The next eponym is Sheehan syndrome, secondary hypothyroidism, named after Harold Leeming Sheehan, 1900 to 1988, a British pathologist. Refers to postpartum pituitary necrosis leading to secondary hypothyroidism, among other endocrine deficiency. The next eponym is Simmons disease, or pituitary cachexia, described by Morris Simmons, 1855 to 1925. Severe hypopituitarism causing secondary hypothyroidism with profound wasting and hormonal deficiency. The final eponym is von Basedow-Graves spectrum. Though mainly hyperthyroid, some patients treated for Graves' disease with surgery or radioiodine can progress to hypothyroidism, named after Karl Adolf von Basedow from Germany and Robert Graves from Ireland. Finally, hypothyroidism in a nutshell. Definition: thyroid hormone deficiency associated with slowed metabolism, slowed growth and cognition. Prevalence 0.3 to 12% worldwide, common in women and elderly. Main cause in iodine insufficient regions, Hashimoto thyroiditis or autoimmune destruction of the thyroid. Symptoms: fatigue, weight gain, cold intolerance, constipation and memory loss. Complications: heart failure, infertility, miscarriage, and in severe cases, mixed edema coma. Treatment: lifelong thyroxine, monitor TSH 6 to 8 weeks after dose change. Key principle of therapy: balance is vital. Both over and under treatment raise cardiovascular risks. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.